Hello, my name is Shebli Atrash and I'm an assistant professor in University of Arkansas for Medical Sciences, Myeloma Institute for Research and Treatment. I'm here at the ASH meeting presenting a study looking at characteristics and prognosis of IgM multiple myeloma. IgM multiple myeloma is an infrequent subtype of multiple myeloma. Its estimated prevalence of multiple myeloma is 0.5%. So to further illustrate the characteristics of such disease, we looked at our database. We looked at all the cases of IgM myeloma in our Myeloma Institute for Research and Therapy. We went retrospectively, looked at the clinical characteristics at presentation for all patients, as well as the presence of bone disease and their gene expression profiling. Then we compared those patients with non-IgM myeloma patients, matched group of non-IgM myeloma patients with the same baseline clinical characteristics, and as well as with Waldenström disease patients. We identified 21 patients with IgM multiple myeloma. 13 patients were presented to our institute and 8 patients were referrals. Out of those 21 patients, we had 15 patients of bone disease at presentation evident by X-rays alone. The rest were 3 patients with bone disease evident by MRI and PET scan. 4 patients had elevated creatinine of more than 2 at presentation. Overall survival for IgM myeloma patient was about 4.9 years in our subgroup. And we compared those overall survival with matched group with same baseline characteristics of non-IgM multiple myeloma patients, and it was not statistically significant. Overall survival was the same for both groups. However, it was largely different from overall survival for Waldenström macroglobulinemia patients. Gene expression profiling was available on 12 patients at presentation out of 21 patients. So we did gene analysis on our patients, comparing them with non-IgM myeloma and Waldenström. Our goal was to separate IgM multiple myeloma from Waldenström macroglobulinemia patients. So first step, we identified the best 1,000 genes that separates non-IgM myeloma from Waldenström macroglobulinemia. Then we did gene clustering, adding IgM myeloma patients. As expected, IgM myeloma patients clustered with the non-IgM myeloma in general, except for 2 patients of IgM myelomas that clustered with Waldenström macroglobulinemia. Those 2 patients, they met the International Myeloma Working Group for Diagnosis of Multiple Myeloma. However, and one of them had renal failure with light chain deposition disease in the kidney. The second patient has diffuse osteoporosis. However, they were special in a way they lack immune paresis, and both patients did not have any discrete bone focal lesions. Also, to better illustrate our results, we did principal component analysis and partial least squares methods to provide 3D imaging showing that IgM myeloma patients are clustering on the same side of boundary plane with IgM myeloma patients, except for those with the rest of non-IgM myeloma patients, except for those 2 patients clustering with Waldenström macroglobulinemia patients. As a conclusion, IgM myeloma is a discrete disease entity that should be differentiated from Waldenström macroglobulinemia. Bone disease is evident on the majority of the patients, especially when we use specialized radiological methods like PET scan and MRI. Also, our gene analysis supports our findings.